Case-based approach. Part 2. How to plan for surgery in vertical squint. Before I start, I want to emphasize that we need to use this chart in order to project the problem and to plan for the best muscle to be operated. We have general rules. We have 5 rules, and I'm going to present these rules in terms of elevators versus depressors, ipsilateral versus contralateral, recti versus obliques, rectus versus rectus, and recti measurements. Starting with the first rule. If squint increases when looking downward, working on depressors is better than on elevators. And if squint increases when looking upward, working on elevators is better than working on depressors. These are the most important rules during vertical squint plan and decision making. Now the second rule says working on ipsilateral muscles is better than working on contralateral muscles. The third rule says working on recti is more predictable than working on obliques. The fourth rule says if there is an equal chance for superior and inferior recti to be operated, consider lid positions. I will come to lid positions. If we work on the superior rectus, the upper lid position will be affected, and if we work on the superior rectus, the lower lid position will be affected. If we do recession to the superior rectus, there might be upper lid retraction, and if we do resection, there might be ptosis. And when we operate on the inferior rectus, if we do recession, there might be lower lid retraction, and if we do resection, we may have lower lid elevation. And we will apply all these rules during discussion of the coming 4 cases. Case number 1. A patient has right eye hypertrophy due to superior oblique palsy. Since he has superior oblique palsy in the right eye, so the options for treatment are either to work on the superior oblique itself or on its antagonist, which is the ipsilateral inferior oblique muscle, or on its yoke muscle, which is the contralateral inferior rectus muscle, or on the yoke muscle of the antagonist or the antagonist of the yoke muscle, which is the superior rectus in the left eye. Of course, it is not recommended to work on the superior oblique because this may cause or this may lead to iatrogenic Brown syndrome. So let's go through rules in order to choose the best muscle to be operated on. Rule number 1, if squint increases when looking downward, working on depressors is better than on elevators, and vice versa. So let us measure the vertical squint in the primary position, upper gaze and down gaze using the prism cover test. So in the primary gaze, the test shows 20 prism diopters. On down gaze, the patient has also 20 prism diopters, and on upper gaze, the patient has 20 prism diopters. So in all directions of gaze, there is equal amount of vertical squint. So we go to the second rule, which says working on ipsilateral muscles is better than working on contralateral muscles. This means that if we work on the inferior oblique in the right eye is better than working on the superior rectus or inferior rectus in the left eye. So in this case, in conclusion, I'm going to operate on the inferior oblique muscle in the right eye. case number 2. The patient has superior oblique palsy in the left eye, so he has left eye hypertropia. If we go to the chart, we find that the superior oblique in the left eye is affected, so we can operate on inferior oblique in the left eye, inferior rectus on the right eye, or superior rectus in the right eye also. Of course, we cannot operate on the superior oblique in order to avoid iatrogenic Brown syndrome. In order to select the best muscle to be operated on, we go through the rules. Rule number 1. If squint increases when looking downward, working on depressors is better than on elevators, and vice versa. So I'm going to measure the amount of hypertropia in the primary position of gaze. It shows 15 prism diopters. Up gaze, it is 10 prism diopters, and down gaze it is 23 prism diopters. So as you see, the amount of hypertropia in the left eye increases on down gaze. So this patient is suffering from walking and reading because these positions need the people to look downward. Now let us see what muscle is the better, which muscle is the better to be operated on. If the squint increases when looking downward, working on depressors is better than on elevators. So it is better to operate on the inferior rectus in the right eye than working on the superior rectus in the right eye or inferior oblique in the left eye, as the superior rectus and inferior oblique are elevators. So I'm going to operate on the inferior rectus. We go through the measurements. Each 1 millimeter on inferior rectus, either recession or resection, corrects 3 prism diopters in the primary position of gaze and 5 prism diopters in down gaze. This is very important. And the same can be said for the superior rectus. Each 1 millimeter of operation on the superior rectus, either recession or resection, corrects 3 prism diopters in the primary position of gaze and 5 prism diopters in up gaze. So 1 millimeter on inferior rectus will correct 3 prism diopters in primary and 5 on down gaze because it is inferior, and each 1 millimeter on superior rectus will correct 3 prism diopters in primary and 5 on up gaze because it is superior. Now, since I'm going to operate on the inferior rectus, I'm going to use this rule. So the patient has 15 prism diopter in the primary position of gaze and 23 prism diopter in the down gaze. If we apply this rule, each 1 millimeter will correct 3 prism diopters in the primary position of gaze. So to correct 15 prism diopters, we need to operate by 5 millimeters on the inferior rectus. But this 5 millimeters will correct 25 prism diopters on down gaze. Now in this case, the patient will have 0 prism diopter in the primary position of gaze, and he will be overcorrected by 2 prism diopters on down gaze. So to avoid overcorrection in down gaze, which is the most important position for working and reading and walking, so I'm going to reduce the amount of correction to be 4.5 millimeters instead of 5 millimeters, which will correct about 22.5 diopters, and it will correct at the same time 13.5 in the primary position of gaze. So the patient will be undercorrected by 1.5 prism diopters in the primary position of gaze and 0.5 prism diopters in down gaze. Actually, these small amounts can be compensated by the fusional amplitude by the patient, and it will be much better than inducing hypercorrection in down gaze. So the rule here is to use the primary position for calculations, but we should not exceed the amount on down gaze. Case number 3. A patient has left eye inferior rectus palsy causing left eye hypertropia, and this is the chart. So we have the following options to be operated: the superior rectus, ipsilateral superior rectus, contralateral superior oblique, and contralateral inferior oblique. To see the best selection, let us go through rule number 1. So in this rule, we have to measure the amount of hypertropia in primary position of gaze. Now the patient has 10 prism diopters in the primary position of gaze, 25 prism diopters in up gaze, and 10 prism diopters in down gaze. So if squint increases when looking upwards, working on elevators is better than on depressors. So according to this rule, we have two options: the ipsilateral superior rectus or contralateral inferior oblique. To see which is better, let us go through rule number 2. Working on ipsilateral muscles is better than working on contralateral muscles. And in rule number 3, working on recti is more predictable than working on obliques. So both these rules are pushing me to work on the superior rectus. So I'm going to work on the superior rectus. Let us do the calculations for the superior rectus. In order to correct 10 prism diopters in the primary position of gaze, we need to operate on the superior rectus by 3 millimeters. Now the 3 millimeters will correct 15 prism diopters on up gaze. So the patient will have 0 in down gaze, 0 in primary position of gaze, and 10 prism diopters in up gaze. 10 prism diopters as undercorrection, and undercorrection in up gaze is not significant as we rarely use up gaze in our daily life. Case number 4. A patient came with left eye hypertropia. Now I'm going to discuss how to find the muscle that is affected and how to find the best option of treatment. Because it is left eye hypertropia, so the accused muscles are left eye superior oblique or inferior rectus, right eye superior rectus, and inferior oblique. I will ask the patient to look to the right. I can see that the left eye hypertropia has increased and disappeared on left gaze. So the two muscles that are accused are right eye superior rectus or left eye superior oblique, because the hypertropia increased when the eyes moved to their field of action to the right side. The next step is to tilt the head. I ask the patient to tilt his head to his right, and I see that the left eye hypertropia has increased, and when he tilts his head to his left, the left hypertropia almost disappeared. So as you see, the superior rectus in the right eye is the affected muscle. Although the hypertropia is in the left eye, but it happens because of the superior rectus weakness in the right eye. The superior rectus weakness causes hypotropia in the right eye, which is presented as hypertropia in the left eye. So the muscles that will be operated are either the superior rectus itself, the affected superior rectus, or the antagonist, which is the inferior rectus, the yoke muscle, which is the left eye inferior oblique, or the antagonist of the yoke muscle, which is the superior oblique in the left eye. Let us go through the rules. I have to measure, of course, the amount of hypertropia in primary position of gaze, up gaze, and down gaze. The patient has 15 prism diopters in the primary position of gaze, 15 prism diopters in up gaze, and 15 prism diopters in down gaze. So we have equal chance for depressors and elevators. It will be equal chance for the three muscles through this rule. The second rule says working on ipsilateral muscles is better than working on contralateral muscles. So it's better to work on the inferior rectus than working on the inferior oblique or superior oblique. We come to the third rule, which says working on recti is more predictable than on obliques. So again, it's better to work on the inferior rectus than working on the two obliques in the left eye. So these two rules guided me to work on the inferior rectus. However, I have now two options, either to work on the superior rectus itself to strengthen it, or to work on the inferior rectus, which is the antagonist, in order to weaken it. So which one is better? We come to rule number 4, rectus versus rectus, which says if there is an equal chance for superior and inferior recti to be operated, consider lid positions. If I operate on the superior rectus by resection, I'm going to induce ptosis. And if I operate on the inferior rectus by recession, I'm going to induce lower lid retraction. We come to rule number 5 in order to judge which one is better. Rule number 5 says each 1 millimeter on inferior rectus corrects 3 prism diopters in primary position and 5 prism diopters in down gaze, and the same can be said for the superior rectus, but 5 prism diopters for up gaze. Let us calculate as if I'm going to operate on the inferior rectus. Since there is 15 prism diopters in primary gaze, and of course up gaze and down gaze, I need to do 5 millimeter on the inferior rectus, but the 5 millimeters will correct 25 prism diopters on down gaze, and this will induce 0 prism diopter in up gaze, 0 prism diopter in primary position of gaze, and 10 prism diopters as hypercorrection on down gaze. So I need to reduce the amount to be 3 millimeters instead of 5, and this will correct 15 prism diopters on down gaze, and I will have 5 prism diopters under correction in up gaze, 5 prism diopters in primary position of gaze, and full correction on down gaze. Now I'll do the same calculations if I want to operate on the superior rectus. I will need 5 millimeters in order to correct the primary position of gaze, but these 5 millimeters will correct 25 prism diopters on up gaze. So the patient will end up with 10 prism diopters of overcorrection on up gaze, 0 prism diopters in primary position of gaze, and 0 prism diopters in down gaze. Now, if I want to avoid hypercorrection in up gaze, I'm going to reduce the amount of correction to be 3 millimeters instead of 5 millimeters, and in this way I'm going to induce correction of 15 prism diopters in up gaze. So the patient will have 0 prism diopter in up gaze, but under correction by 10 prism diopters in primary position of gaze, and under correction by 10 prism diopters in down gaze. Now, as you see, we have 4 possibilities. We can summarize the possible possibilities here. If I want to work on the superior rectus 5 millimeters, I'm going to induce hypercorrection in up gaze by 10 prism diopters, and if I operate on the superior rectus by 3 millimeters, I'm going to induce hypocorrection or undercorrection on primary position of gaze and down gaze. And if I operate on the inferior rectus by 5 millimeters, I'm going to induce overcorrection in the down gaze by 10 prism diopters, and if I operate by 3 millimeters, I'm going to induce undercorrection in upper gaze and primary position of gaze. Of course, we have to avoid any hypercorrection or overcorrection in down gaze, and we have to avoid hypocorrection or undercorrection in such amount in down gaze. So we have only two options, either to operate 5 millimeters on the superior rectus or 3 millimeters on the inferior rectus. Now we come to the positions. If I operate 5 millimeters on the superior rectus, I'm going to induce ptosis, while if I operate 3 millimeters on the inferior rectus, I am maybe, and it is a very low possibility, I will induce lower lid retraction, as it is a small amount of correction, 3 millimeters only. So the best option is to operate on the inferior rectus by 3 millimeters. To conclude, always use the charts to diagnose and plan. Measure vertical squint in primary position, up gaze and down gaze. Use the 5 rules to plan. Don't over or under correct on down gaze, as it is important for reading and walking. And finally, small amount of undercorrection or overcorrection on up gaze will not affect, as we rarely use this position of gaze in our daily life. Thank you very much. I hope that you enjoyed, and I would like to invite you to Sinjab Academy on Telegram, where you will enjoy a lot of discussions on refractive surgery, topography, keratoconus management, and much more. Goodbye.